Hi, everyone. Good evening. So nice to see you here with us live in person for the Neighborhood Health Series. Many of you have been coming for a long time and came along with us as we went virtual during COVID. And we're now back in person. This is the second in-person event we've had. So is there anyone here today that's never been in this building? Okay, great. And probably you don't know much about Roseman. Is that a fair assumption? Okay. So Roseman's been around for about 20 years, Roseman University of Health Sciences, and Roseman focuses primarily on graduate health sciences programs. This event and this series was created to bring our community in and get them to learn more about healthcare and some of our providers and some of our experts and our scientists. We have 4 nursing programs. We have a dental school in Utah. We have an orthodontic residency here. We also have both a dental and orthodontic clinic that offers reduced cost care to our public. We also have the first and only College of Pharmacy in the state of Nevada. And let's see, did I miss anything? And we have the College of Graduate Studies, which has a master's in biomedical sciences and also a master's in pharmaceutical sciences. So those are some of our programs. And we are in fact bringing our College of Dental Medicine down here to Utah. And it will be actually right on this campus where we'll have students training to be dentists. So it's very, very exciting. And we're also building a College of Medicine, and that is in development. So a second College of Medicine here for our Nevada community. And as you know, we have quite a bit of a shortage of physicians and an aging population and a lot of physicians that are retiring. So it's very important for us to fill those healthcare gaps. So I mentioned our dental clinics. We also have a primary care clinic called Roseman Medical Group that's over in Spring Valley Hospital. And that is a wonderful primary care practice that helps see patients. It doesn't have long waits. You can get in relatively quickly. So that is a really nice part of our university, and a lot of our faculty and employees use all of our clinics. So I just wanted to tell you a little bit about Roseman before we start. And before we start, I'd also like to first welcome Craig Fraley, who's from Clark County Credit Union. Clark County Credit Union is our sponsor. Without them, we would not be able to do this. And with that, I'd like to let Craig say a few words.
They'll hear me.
Sure. Okay.
Yeah. Excuse me, lady.
No, the Zoom.
No, it's okay.
Zoom won't
Okay. Oh, Zoom won't be. I'm sorry. Good evening, everybody. We are the Medical Field Credit Union. We are always very proud to sponsor these events with Roseman. We've been doing these how many years now? 7 years. Wow. And I've been here for the whole time, so it's been great. So if you ever need financial wellness, please reach out to us. There's magazines on the table outside, full information, how you can contact us. You can do everything right on the phone. Real quickly, just to let you know, we are not for profit. We are owned by our members. At the end of the year, we take our profits and we give it to the membership. That's millions of dollars every year that goes back into our members' accounts. Since year 2000, it's been over $70 million. And I'm talking around 50,000 people. That is not a bad pool to be in. I also have left on the table over there a stack of $1 million bills. Please take some. It is illegal to make fake money. It has to be real. All right, everybody, have a wonderful evening. Thank you.
Thank you. We also have, as you can see, Dr. Glassman has one, our flyer, which shows the remaining Neighborhood Health Series for the rest of the year, and all of next year has been planned out. So please come to the website and check out the upcoming events. It's been planned and we're very excited. So now I'd like to introduce you to our very, very special guests. Danielle Chung, Director of Marketing at SDMI, has been an absolute pleasure to collaborate with over the past several months. Danielle joined SDMI in 2013, and they quickly realized her unique skill set could be put to a multitude of uses. Lucky you. She was promoted to Assistant Marketing Director and then to Marketing Director in 2017. Danielle found her niche working in marketing, where she's given the opportunity to be involved in many aspects of the business, from sales and business development to traditional marketing tasks, patient and employment engagement, and even operations and implementation of new products and processes. Dr. Aanshu Shah here is the Director of Women's Imaging at SDMI. She completed her undergrad study at Michigan State and attended University of Michigan Medical School. She completed her residency at the University of Pittsburgh and her fellowship at McGee's Women's Hospital. Dr. Shah works in multiple capacities, serving our community through community partnerships and outreach, and we are very grateful to have both of them here today. So please join me in welcoming our guests.
Good evening, everyone. Welcome. How many of you are familiar with Steinberg Diagnostics? I'm going to go through a quick kind of run through about the practice, but I don't want to get too in depth if you guys are regular visitors and are familiar with us. Oh, no. He promised me the little things would work. Okay. Tech friend. There we go. All right. So just really quick, if you've been in Vegas for a long time, you know Dr. Leon Steinberg was one of the very first radiologists in this town. He started with Sunrise Hospital and founded Steinberg Diagnostic on the philosophy that if you practice great medicine, patients will follow. That is a philosophy that the practice holds to this day. We are the only locally owned and operated radiology facility in Southern Nevada. We have everything is in-house, from billing and collections to maintenance and laundry and anything in between. We have a full IT staff. We have an HIT department. So everything is done in-house. So we're very proud of that fact that we are locally owned and operated. These are some of the many accreditations that you can find at Steinberg Diagnostic. The ones that I do want to point out, AAAHC in the top left, that is a voluntary accreditation where we invite people to come into our practice and audit every single thing that we do, and then to give us a score at the end of the year. We do not get to display this seal unless we pass that audit every 3 years with them. The one next to that, a Diagnostic Imaging Center of Excellence, is important in that if you don't have all of the seals underneath and you are not accredited by the ACR in every single modality, you cannot be a Diagnostic Imaging Center of Excellence, and you have to hold that accreditation at every single facility you have. It is not given to you practice-wide, and we do hold that accreditation at all of our 10, soon to be 11 locations. Technology is something that Steinberg Diagnostic is extremely proud of. Dr. David Steinberg and Dr. Mark Winkler run the practice. They have been there since day one, and they are both incredibly passionate about technology. We have some equipment that was first installed in the United States. We have some equipment that was first installed in the world. We work very, very closely with the manufacturers and the development. They're very passionate about making sure that we get the top of the line equipment, the best images, the best quality, so that we can get referring physicians the best reports back for patient care. So here's just a few of the ones that have come in first in the world, first in the US. Just kind of a big overview, and then of course, first in Nevada. Patient-focused care. So all of our radiologists are subspecialty trained. So you'll hear from Dr. Shah. She is subspecialized in women's imaging. That's her specialty. We have specialists in all of those categories. So you can be assured that whatever you're coming in for, your scans are being read by somebody who trained specifically in those studies. We also offer a lot of technology advances. So not only is our equipment top of the line, but all of the things that make the practice run. We have a patient portal that allows you to have access to your images and reports the second they are signed off on by the radiologist. So you can log in, get your image, get your reports, even before your referring doctor gets back to you. You have those right away at your fingertips. We also offer online scheduling. We know that phone wait times for healthcare practices can be a little lengthy these days. So we do offer online scheduling. It is not available, just as a caveat, for some of the more advanced things like PET scans, nuke med, biopsies, things like that. Those do take a little bit of extra time and care. So we like to make sure that a specialist schedules those. And then we also offer all of the same things for our referring physicians. They are able to pull images electronically. They have access to reports at the same time. As soon as they're signed off, they're allowed to track patients in our system. They know if you reschedule, if you cancel, if you don't show. They know everything that you do when you walk through our practice. They also have the ability to schedule you in our system if that works for their workflow. So we have a lot of options available out there for the referring physicians. And then this is just a snippet of our current 10 locations. We do have an 11th location opening early next year at the corner of Wallapai and Alta. So that will be our Summerlin location. And with that, I will hand it over to Dr. Shah to get into our breast cancer awareness.
By the way, do you have dual modality scanners and readers?
We will get to all those questions at the end of the presentation, if you don't mind.
Right. Can everybody hear me? Okay, I'm not as loud as everybody else here. Good evening, everyone. My name is Aanshu Shah. I'm the Director of Women's Imaging at Steinberg Diagnostics, and I am so excited to be here today. I am so passionate about mammography, and I'm very eager to share all the information I have with you. I want to thank Danielle and Roseman University for having me, first of all, and Vanessa, Danielle's over there, Vanessa for having me, and also Danielle for asking me to speak tonight. So I have been with Steinberg for almost 20 plus years, and I have seen tremendous growth. When I was with Steinberg, we only had 4 offices, and now we are opening our 11th office. I was the 7th radiologist, and now we are up to 30 radiologists. So I have seen quite an evolution of our practice, and I've been very proud to be a part of it. So today I'm going to be talking to you about breast cancer mammography in honor of Breast Cancer Awareness Month. And if you don't mind holding your questions to the end so we can address them in one big group, because I have a ton of information and hopefully I will get to your questions as we go through the talk. So first of all, why even get a mammogram? Well, over 280,000 women in the United States are expected to be diagnosed with breast cancer just this year. And unfortunately, up to 43,000 of those women will die from breast cancer. 30% of the new diagnoses of cancer in women will be breast cancer, and that's only secondary to lung cancer. It's very unfortunate that breast cancer can be such a killer. So what can we do? And mammography is really our only defense against breast cancer right now. 3.8 million women have been touched by breast cancer in some way. They're either fighting it, have had it, or are currently being diagnosed with it. I'm sure all of you know somebody or have been touched by breast cancer in some way as well. So why do we want to do a mammogram? The biggest advantage of doing a mammogram is finding breast cancer when it's very, very small. In fact, if we can find breast cancer before you have symptoms, before it's over 2 centimeters in size, the 5-year survival rates for breast cancer are over 99%. So the goal is to find cancer before you even know it's in your body. And mammography is our only way to do that right now. So when should you get a mammogram? The American Cancer Society and the American College of Radiology all recommend that we start getting mammograms beginning at the age of 40. That's it, period, end. I don't know what else you may have heard, but every year after 40 is the current recommendation. Of course, if you have a symptom, and I'll talk about what those are in a minute, if you have a symptom, you need to talk to your doctor and we can get the mammogram scheduled right away. Also, if you have a family history, there are certain indications for getting the mammogram earlier than 40. And especially if you have a first-degree relative, there can be genetic links to breast cancer. And so we would recommend getting a mammogram earlier than 40 in that instance as well. So what are some of the symptoms that you should be looking out for as you do your exams on yourself? We're looking for nipple inversion or nipple turning inward. We're looking for nipple discharge, particularly involving only one breast, particularly involving the colors that are clear or red, meaning and bloody. We're looking for any swellings or lumps in the breast or the underarm area. We're looking for any breast pain or nipple pain. We're looking for skin dimpling or skin irritation, specifically around the nipple area. That can be a sign, a very early sign of breast cancer as well. So what are the risks? There are several risks that unfortunately we cannot control, and that's obviously going to be, for example, gender. If you're a woman, you're obviously going to be at a greater risk for breast cancer. Age, most women over the age of 55, we've seen an increased risk of breast cancer in that particular age group. Also, genetic changes. Some women will have the BRCA1 or BRCA2 mutation, and these women will know that they have that because they have family members that have breast cancer, and it's going to be something that's linked genetically. Race, overall, Caucasian women tend to be slightly more likely to develop breast cancer than African-American women, but the women that are under 40 tend to be African-American, and African-American women, unfortunately, are more likely to die from breast cancer at any age. If you've had chest radiation therapy, for example, if you've had radiation treatment for lymphoma, non-Hodgkin's lymphoma, or thyroid cancer, you can and your breast can actually be in the zone of radiation, and that can increase your risk of breast cancer as well. And also if you've had a history of breast cancer or an abnormal biopsy or a pre-malignant biopsy result, that can also increase your risk. So what are the risks that you can control? Well, if you exercise, you reduce your risk of breast cancer. We're not sure exactly why, but it can be due to the effect of the body weight. Inflammation and hormone levels can all be decreased with exercise, and that can decrease your risk for breast cancer. Alcohol use, even 1 drink a day, can increase your risk of breast cancer by up to 7%. And also, if you have an enlarged body habitus or considered overweight, having more adipose tissue or fat tissue can actually increase your estrogen levels, because the majority of the estrogen is made in the fat cells of your body, and that can also increase your risk. After I said that, probably the most important slide I'm going to show you today is this one. Most women think because I don't have any family history or I don't have any risk factors, I don't need to worry about it. I don't need to get a mammogram. 85% of the women I diagnose with breast cancer have no family history and have no risk factors. And that's scary, because that's coming from out of the blue. And again, mammography is our only way to look for that breast cancer. I talked about earlier, if you have other indications to having a mammogram before the age of 40, we have a rule, or we follow this in the field of radiology, that if you have a family member that's been diagnosed with breast cancer, we recommend that your first degree relatives start screening 10 years prior to that person's diagnosis. So for example, if your mother was diagnosed at the age of 40, we would recommend that the daughter, the sister, begin their screening mammograms at the age of 30. So how is the mammogram performed? Basically, we do 2 views of each breast. We do a top to bottom view and a side to side view. The breast is compressed for about 5 seconds, and we do 2 additional views if you have implants on each breast. You can decrease the discomfort of your mammogram by scheduling during the ideal time of your menstrual cycle. We recommend you do it right after you've had your cycle, just before ovulation. That's when the hormonal influences on the breast are the least, and that's when you're going to have less discomfort during compression. So fortunately, we do have someone who recently turned 40 and had a mammogram, and I thought it would be kind of nice for her to kind of walk us through what it would be like to have a mammogram. So Danielle, do you want to do that for us? Yeah.
All right. Is there anyone in here who has not had a mammo? Perfect. Okay. Some of you that were supposed to raise your hands did. All right. So I was, obviously we all know I just turned 40 not that long ago. So I was born in 1981. So I don't feel bad about telling you what year I was born. And I grew up with my mom and my stepmom and my grandmothers coming home telling us that they had just been to see The Vice and they had been run over by a steamroller and all of these horrible things about how awful it is to get a mammogram. And so even though I have spent almost the last 9 years doing things like this talk, writing articles, blog posts, social media posts, trying to convince women that they need to get their mammogram, when it came time for my first mammo, I put it off until my referral almost expired. So you have 1 year from the date your referral is written to get your annual mammogram. I waited up until about 11 months. So I too had, of course, Dr. Shah, my good angel, yelling at me to go get it and telling me how it was going to be okay. But the history of hearing how horrible it was won out for quite a long time. So the lesson here is really don't put it off. It really does, it doesn't take very long. But I also want to go through just what to expect when you do schedule. So like I mentioned before, online scheduling is available. We will schedule you even if we don't have your referral on hand. As long as we have it by the day of your appointment, you can still get on the schedule. You have up to a year from the date. So if you haven't gotten yours yet and you have a referral, you still have plenty of time. Appointment day is very easy. The hardest part of the entire thing was not being able to put on deodorant or lotion that morning. So I think that was the biggest struggle. And I've heard from all of the techs that that's probably the biggest complaint that we get from our patients. A quick, easy check-in paperwork. One of the things I do like to note is not at all of our locations, but at several of our locations, we do have women-only waiting areas. So if that is something that is important to you, make sure you mention that during scheduling so that we can schedule you at a location that is women-only. And then the exam itself really is very quick. This is actually a real life picture of my exam. I promise there will not be photographers there for your mammo, but they allowed me to bring them in for mine so that we could capture the fateful moment. And it really, what I walked away with is that it was not bad at all. It was incredibly doable. This position, the front position, honestly, the hardest part was having your head in the angle to get it out of the way of the field of view. That was more uncomfortable than the compression. And then the side view, that plate that you can see that the breast rests on, that kind of gets up into your rib cage a little bit on the side view. And I would say that's the hardest part of that side. But by the time I had even a moment to think about whether I was uncomfortable or not, the tech was done and the compression was off and I was able to move around. If you haven't had a mammo in a while, I know you used to have to hold your breath during the whole thing. That is not the case anymore. We let you breathe now. So that's a huge advancement in technology that we have had. And then just a reminder, results are in the patient portal, so you can get them very quickly. You don't need to wait for your follow-up appointment, especially if it is several months off and you want to put your mind at ease. You can read that report right away, and then you will also get a letter in the mail.
All right, thank you, Danielle. So basically now we know why to get a mammogram. We want to find that cancer before it's symptomatic and before it's 2 centimeters in size or greater. And now we know how to get a mammogram, thanks to Danielle. So now we get to my part. What am I looking for when I see your mammogram? So you've done everything you're supposed to do. You've gotten your referral, you've gone to your doctor, you've gotten your mammogram, and you went and got your mammogram done. So now the images are sent over to me. So today I'm going to give you a sneak peek on what happens to that on that side of the discussion. So the first thing I do when I see a mammogram is I have to evaluate the density of the mammogram. That's going to be the first line in every report on mammography. So what I'm looking for is basically how dense is your breast? How much white tissue do you have? So the image on your, I believe that's the left, right? The left is going to be the breast that has the least amount of glandular tissue. And as we move to the middle image, you see a heterogeneous dense, so you see even more white tissue. That means even more dense. And then the last image on the right is your very dense, extremely dense tissue, and where there's a ton of white tissue there. So every woman is going to come in with different densities, and that's normal. And in fact, even the same woman can have a different density in the same person. The right breast can be different from the left breast, and that's completely normal. That's not an abnormal finding. So the next thing I look for is the breast cancer. What does breast cancer look like on a mammogram? Well, the image on the left is probably the most common presentation. It looks like a dense speculated mass. Does this little mouse guy work here? So it's this area right here. It's a dense speculated mass. The other way it can present is something called microcalcifications. And this is a magnified view. These are actually no bigger than a grain of salt. So it's a cluster of microcalcifications. These can be a very early form of breast cancer called ductal carcinoma in situ. So the image on the left is the speculated mass. Unfortunately, I'm seeing this on a patient who has very easy breasts to read. There's not much white tissue. But on a woman who's got a very dense breast, you can imagine how difficult it would be to find this very speculated dense mass. To make things even more difficult for me is 40% of women who come in for their mammogram have dense breasts. So it's a very challenging field, but it's a I have a lot of technology around me that's made that job for me a lot easier. And I'm going to share that with you right now. A couple of years ago, we got something called 2D or 3D mammography, and that has pretty much revolutionized the way we read mammograms. And I'll show you more about that in a minute. Some women get nervous when you go in for your mammogram and you get a letter in the mail saying you need to come back and get additional views done. And that's very, very scary. But really all that means is that I saw something that I'm not sure about, that I'm concerned about, and I need to get additional pictures just to see if that's a real finding or not. 8 out of 10 of those people that come back to see me go home with completely normal mammograms and a completely normal reading. So just because you get called back doesn't mean that you have breast cancer. It doesn't mean that everything's gonna, crumble down and your life's gonna change. It just means that we just need to take a few extra pictures, take some time out of your day and come back and get those extra pictures done. All right, so 3D mammography, or something we call tomosynthesis, which now we offer at all of our Steinberg locations, and we have for several years now. Every woman who comes in for a mammogram, David Steinberg believes should get a 3D mammogram. And that's something we've offered to every woman from the moment we've got this new technology. It has allowed us to increase our detection of breast cancer. It's reduced our number of callbacks and false positives. It's done with no additional radiation to the patient. And it's also led to fewer follow-up tests and biopsies. So what exactly is 3D mammography? So I want you to envision a loaf of bread, okay? A loaf of bread is your 2D mammogram, okay? Now 3D mammography is that loaf of bread, but now I can actually pull out those slices of bread and look at them one by one. Okay, so that's where 3D mammography has really helped me. In those dense breasts now, I can actually see slices of the breast tissue and analyze it much more effectively. So here we have a 2D mammogram. The image on the left, this one right here, was done last year on a young woman. She comes in a year later and has another 2D mammogram. And I don't know if you can appreciate the subtle difference. I'm sure the circle here is going to help you, but she's had the interval development of a new speculated mass. And it's a subtle finding, but I also put this slide in to show you how important having the previous films are, because my eye caught this right away because I sensed the change. But if someone were to walk in with this mammogram right here, this finding may not be so obvious, right? I mean, to my eye now that I've done this so many years, I probably would be, but the subtle change really helps me. So when we have you sign up to get a mammogram and we ask you to bring in your prior films, this is why, because the subtle changes are actually going to cue my eye even faster than just looking at it de novo. Now, I want you to compare this 2D mammogram to the 3D mammogram I'm going to show you on the next slide. This is the same patient. And how do I play this? Is it, oh, there we go. Okay, perfect. So we're going to play the tomo image, which shows you slice by slice, and you can see, oh, sorry. I was trying to slow it down for you, but you can see the image. This area just pops right out. So for me to read mammograms, I have to now, instead of reading 4 images, which is what I did with 2D mammography, I read 80 to 90 images per patient because I'm looking at all the slices. So our read time has increased a little bit, but our accuracy has definitely improved. So the other thing I wanted to tell you is that not all tomosynthesis equipment is equal. SDMI selected the GE Pristina technology because it delivers no more radiation to the patient than a regular 2D mammogram. And not all 3D mammography units can say that. So it was very important to our facility and to me that we not expose our women to any more radiation. Getting a mammogram every year is enough. So that was very important when we were deciding which equipment to get. When you come in for a mammogram, people often ask me is, why are you compressing my breast tissue? Why are we putting compression on the patient? And the reason we're doing that is to spread the breast tissue out as much as we can, because things can overlap, especially in dense breasts. So we're pressing areas specifically to spread the tissue out and make those speculated areas that are catching my eye go away. It also decreases the motion. So here's an example of a patient who had a mammogram, and we saw this small speculated mass right here. We brought her in for a spot compression view. You can tell because there's a specific paddle here, this rectangular paddle here to compress the tissue in that specific area. And that area has now completely gone away. So this would be one of those 8 out of 10 patients who are just going to go home happy as can be that they don't have anything to worry about. But that's why we did the compression view. We're not doing it to hurt you or to make you uncomfortable or to torture you in any way. We're doing this to hopefully save lives. When you call in to make your appointment, you may get asked a question whether you're getting a screening mammogram or a diagnostic mammogram. Screening mammogram is a patient who comes in with no symptoms. It's an annual exam that we do on everybody after the age of 40. Diagnostic mammogram will be something that you would probably be ordered by your physician if you presented with a symptom of some kind, or if you're high risk, or if you have a history of breast cancer, or if you've had if you have a genetic predisposition, have the BRCA1 or BRCA2 gene. All right, so you had an abnormal mammogram. You came in for your spot views and you did your diagnostic mammogram, but you still have something abnormal. So the next thing that's going to happen is the radiologist will probably recommend that you have an ultrasound or an MRI, or even go straight to biopsy. So I just wanted to touch briefly on each of those. So ultrasound is done usually to characterize masses in the breast. Not all speculated masses are cancer, not all round, simple looking masses are cancer. So we do an ultrasound to characterize the area to make sure that we're not dealing with a cyst versus a solid lesion. We also do ultrasounds in younger women to avoid the exposure to radiation and start out with the ultrasound first. If we can say what they're feeling is a cyst, we don't need to do the mammogram. Some people ask me if we can just do the ultrasound and not do the mammogram. They, for whatever reason, don't want to have the mammogram done. Can I just have the ultrasound done? You can, but ultrasound will not see microcalcifications. And microcalcifications are the most common presentation, one of the most common presentation of early breast cancers. So it's not a good screening tool. Mammography is still our gold standard. Breast MRI. Breast MRI is a very unique imaging modality that we have that's been a very, very useful in patients that, especially high-risk patients, patients that have breast cancer. We're trying to determine how much cancer is in the breast. We're looking for responses to chemotherapy. We're looking for carcinomas in patients that have unknown primaries, and also in patients with suspicious nipple discharge. We keep our indications for breast MR very, very specific. MRI is a very expensive exam. It takes 2 to 3 times as long to do a MRI. There's a very high rate of false positives. And also the other indication for MRI, most women say, can I not get the mammogram and just get the MRI? Well, MRI can't see microcalcifications either. So again, mammography is our gold standard. All right, biopsies. This is an example of a stereotactic biopsy. In the breast, we do 2 types of biopsies. One is called stereotactic biopsy. One is called ultrasound guided biopsy. We use ultrasound to look to biopsy masses, and we do stereotactic biopsy to biopsy the microcalcifications. So what is the difference? Ultrasound, we have the patient lie on their back. We're looking for a mass that we can see on mammogram and on ultrasound. Stereotactic biopsy is the patient's going to lie on their stomach, their breast hangs through a small hole, and we actually are able to analyze through the mammogram machine and find those calcifications. Sometimes we do masses on stereotactic biopsy as well, and we do that when we cannot see the mass on the ultrasound device. And we also can evaluate subtle architectural distortion in the breast, and we can also biopsy that with stereotactic biopsy. Both ultrasound and stereo do use the same size needle. Sometimes we use a larger needle with stereotactic biopsy. And after biopsy, we do place a small clip at the site of where we did our biopsy. This is something to just to mark the area where we did the biopsy. So the surgeon will know where to go if the tissue is abnormal. And also it's a reminder to the radiologist every year if you come back, and just have us remember to take an extra close look at that area because you've had a biopsy there. It's not going to set off any metal detectors. It's an inert metal similar to what's used in joint replacements. I just wanted to briefly touch on male breast cancer. It is out there. We do diagnose almost 3,000 cases per year. Symptoms are very similar to women. The most common presentation that I see for men is gynecomastia. This is an abnormal development of breast tissue in a male. It typically happens only in one breast. Usually this happens because of abnormality in the hormone levels. It also can happen because of steroid use. A lot of bodybuilders out there don't realize that that can be a side effect. The use of marijuana can cause breast tissue development. And it also is a very common side effect of some of the hypertensive medications and the reflux medications that are out there. But your doctor should warn you or let you know before you go on any of those. So we've come a long way in radiology, and we used to have magnifying glass and plain films and you know, sit there in front of our light boxes and pull our films down and one by one load them up. Now everything is digital and computerized. I feel like an airport control operator sometimes looking at all my 757, you know, computer screens. But it's very exciting to watch the changes that are happening in radiology. Again, my specialty is mammography, but I did want to basically touch a little bit on some of the advances that are happening in radiology. Artificial intelligence and computer-assisted detection has really helped us in mammography, especially. We can actually apply a filter when I'm reading mammograms that can actually analyze the image. Every mammogram at Steinberg is computer analyzed as well after I've read them. And we have a double check device kind of to look at each mammogram. I think in the future, breast cancer is going to be more patient personalized. I think as AI gets more involved in radiology, we're going to be able to specifically design our imaging and our follow-up and our treatment based on everybody's specific risk factors. There's been a lot of new developments in PET scan. We have a lot of new radiopharmaceuticals being used, especially for prostate cancer and for ovarian cancer. We also have a new device coming out called the PET, not only PET CT, but also a PET bone scan, where we're actually overlaying our PET, able to overlay our PET imaging on top of bone scans. And this is very new and up and coming in our facility. We also do low dose CT for lung screening, lung cancer screening, and we also do calcium scoring for cardiac evaluations. We're also doing a lot of 3D imaging as well. So that's about all I have to offer you today. Thank you for having me. I'm here for any questions, and please feel free. Go ahead. I saw your hand go up first.
Before I ask my question,
Sure.
we have a spelling error.
Oh,
The vice that you refer to with the steamroller is spelled with an S.
okay.
What you spelled is cardinal sins.
Okay. All right. I will make that adjustment. Thank you for bringing. Okay, please go ahead.
I wanted to know if there's any data, and if there isn't, are people starting to collect data on transsexual male to female who are being exposed to estrogen throughout the rest of their life? Does this have any effect on increasing breast cancer in these people?
I believe there's a lot of studies going on right now. From what I understand, the risk factors are the similar as if you were female. The estrogen effects and the risk factors, et cetera, are all very, very similar. That's currently how we're treating it.
But we don't have the data yet.
Correct.
Okay, that's what I.
Correct.
read out.
Correct. It's still up and coming.
Do you use any contrast agents in your modalities?
So there is actually a modality called contrast enhanced mammography. It's a new area that's coming into use. But right now, I don't feel like that is superior to breast MRI. And also, I do not like to expose my patients to radiation if I don't have to.
So you
Or
don't
dye.
use gadolinium in a
That's a completely different one. We use an iodinated contrast for CT or for mammography, and we use a completely different gadolinium for MRI, which is more safer and inert contrast agent. So right now, I feel like breast MRI is much superior to doing a contrast enhanced mammogram right now. The studies are also concordant with that. I believe there are certain indications where we could possibly do it, but right now, breast MRI is so much better. Yes.
What is the percentage of false positives on the 3D mammogram now?
The false positive rate on 3D mammography. Well, we were increasing our detection of breast cancer by up to 40%. Our false positive rate, I wish I could give you an exact number. It's getting lower and lower as people get more and more involved in the field. I mean, in the beginning, it definitely was much higher because the learning curve. I mean, I was calling things back left and right just because I was still learning myself. The national average should be about 10%. But it's kind of, I don't know, it's evolving. I'll just leave it at that. Yes.
I have a question about portal. If I understand correctly, once you have the scanning or the MRI, you can view and report, just like the physician.
Yes.
That is correct.
Can a surgeon that you've been referred to out of state also access that? You still have to pick up the maybe.
So
this-
you as a patient can email the study through the portal to a specialist. Or we as the practice can email it to a specialist that is not currently signed up as a referring physician to access our referring
But
portal.
it can be done by email. now.
Absolutely.
No longer do I have to pick up.
You
this
know-
email.
Correct.
Thank you.
Yeah, absolutely.
Absolutely. Yes, sir.
First of all, Dr. Shah, thank you for an excellent
Absolutely.
presentation.
Absolutely.
I have a couple of questions.
Sure.
First of all, is the symptomatology in males similar to the one in females?
Yes, it is. Males will present with abnormal mass. Usually in males, when they feel something, if it's behind the nipple, I'm thinking gynecomastia. If it's anywhere else in the breast, definitely. They will also present with the very similar symptoms to females. Other than that,
Second question in a different area, with the mammography. What is the radiation that is?
it's a very, very small amount. It's equivalent to taking a cross-country
That's
flight
what
across the
I-
country. It's measured in milligrays. It's usually 2 to 3 milligrays per view.
Is it X-ray?
It's X-ray. Yes, it is radiation X-ray. Yes.
And finally, could you please explain me what is the difference between an MRI and a CT scan?
Sure. So MRI is used mainly to look at soft tissue abnormalities. We see a lot of, it's used mainly for, I guess that's the best way to say it. CT actually shows us a lot of bone detail and soft tissue detail, but MRI shows us soft tissue detail in a much more, it allows us to evaluate it in much better detail. We're able to see the water content, we're able to see the soft tissue content in MRI versus in CT, we're kind of limited by just how it is in one view. But with MRI, we do different sequences where we can enhance the fat content of a lesion. We can enhance the water content of a lesion, and we can learn much more about soft tissue abnormalities on MRI. Versus CT scan, we get a quick general look of something, and we can also look at bony abnormalities, which we can't see on MRI.
Thank you.
Yes.
I'm gonna just jump back to this question that you had about the portal, because I know something was mentioned about Hipaa compliance with emailing images. So I just want to touch on how that process works. So you as the patient would log into your portal, you would email a link to your specialist physician, and then you would give them a PIN code separately outside of that email link that would allow them, when they click on that link, to put that PIN code in, which would give them access to those images. So that's how that remains HIPAA compliant, to make sure that nobody can just click on that link and grab your images. And then also to your MRI and CT question, we do have a blog post up on our website that talks about the differences in a little bit more detail if you'd like to go through that.
Yeah, wait, go ahead. Go ahead.
Actually, you mentioned the only diagnostic technique is radiographic. How long ago did you get rid of your lunar machines?
Ooh,
About
probably 10 years.
that, okay, so that happened after. You are aware of, there is that database of methylation group changes to predict or to analyze breast cancer, and also looking at histology. It was part of the lunar process about 3 years ago.
So we did have a nuclear medicine. He's talking about nuclear medicine studies.
No, epigenetic,
Epigenetic.
yes, methylation groups.
Okay, I've not heard
University
of that.
Broad Institute.
Hmm.
Oh, never mind, if you're not familiar with it.
No, I'm not familiar with
Okay,
that.
that's
I'm not familiar with that, but I want to talk to you about this afterwards, definitely. Yes, sir.
Do you do any fully automated reads without a human involved?
Absolutely not.
Do you do partial reads, preliminary reads, or? with the-
We only do computer use with after they've been evaluated with the human eye. Only after, yeah. I think the learning curve with artificial intelligence is still going up. They call back a lot more than I do. And so I think it's a useful tool, but I think you will never replace the human eye in terms of making that subtle distinction. If I called back everything that the computer, everybody here would be getting mammograms and coming, our office would be exploding with appointments. So we always still need the human eye to make that distinction. And I think as time goes on, that may get less and less, but right now it just is the last button I hit before I close the case, just to make sure I didn't miss anything. Yes, ma'am.
I know we start at 40 mammograms. Providing, there's not been a problem over the years. At what point do you recommend not needing?
That's a good question. I do mammograms on 90-year-old women. I do mammograms on 30, 25-year-old women. So, I mean, it's really up to the patient. I have some women that want to keep coming in no matter what. They feel like as long as they have 2 legs and can walk, why not get your mammogram, right? It's going to save their lives. So it's really a individual call. I don't think there's a specific age where you stop. I don't think it's there. So, yes.
Well, I was wondering, are you familiar with the iudents.org website and their arguments? I mean, you said microcalcifications really are only picked up on mammograms, but it just seemed like, a lot of women don't get diagnosed because of just having a mammogram, at least from the statistics I read on it.
So the way that we've kind of tried to help that, I mean, even if you have dense breasts, there's always a chance we're going to miss the cancer, right? There's always a chance. So a lot of studies have now come out with the people getting an ultrasound and a mammogram at the same time. And that's actually helped us quite a bit. And it's still a lot of studies happening with that because ultrasound has its own issues with false positives, but in dense breasts, specifically in women that are high risk, we definitely do recommend getting the ultrasound done as well.
Okay.
But 3D mammography has helped us a lot.
There's one more question.
Sure.
So how can you tell when you look at a mammogram if there's radiation damage from maybe prior cancer, breast cancer? How can you tell if it's radiation scar tissue or whether it's a new spot?
Yeah, that's a great question. And that, I mean, I see that every day. So what I look for is consistency in the mammogram. I'm looking at the scar. It should be involuting. It should be contracting. It should be getting smaller. Anything that's doing the opposite of that, I'm gonna flag and get an MRI. MRI is the best way to kind of tell me if there's enhancement there, then I know there's active disease there. But I'm following your mammogram, I'm watching it, and I'm watching that scar every year. That's why specifically in patients that have been treated in the past, previous films are so important.
And how many years should a patient bring their films in if they wanted to switch and come in?
As many years as you can give me, I'll take them. I'll take them. Many years. Yes, sir.
What kind of MRIs do you have? Do you have a 1.5 Tesla, 3, a 5, an 8?
We have 1.5, 3.0.
We have 3s. I'm probably going to botch the numbers, but I want to say we have 10 3, 10 1.5s, and maybe 5 or 6 3.0s. We've got them at almost every location. We have several MRIs that were first installed in the US and in the world. One of our founding doctors is incredibly passionate about MRI technology. So he has worked with Toshiba, which is now Canon, directly now working very closely with GE on the development of protocols and equipment and all of the nuances that go along with that. So yeah, we have all of the, something to note though about, and I am not an expert, I am not clinical by any means, my knowledge is dangerously close to knowing something. But something to note about a 1.5T versus a 3T MRI, just because the number is bigger doesn't make it better. It's
smaller things.
It's dependent on the type of study that you're having. So we will schedule you based on what you're having done on the machine that is best to see what they need to see. So, and that's something that an MRI person could go into much more detail for you if you have specific questions. I can certainly put you in contact with somebody who knows a lot more than I do. But bigger number doesn't always mean better. It's just that 3T is better at seeing certain things and certain body parts, and a 1.5T is better at seeing certain things in different body parts.
True, yeah.
Absolutely.
Can you speak to self-breast exam and the importance of it? Does it play a part?
Absolutely. So the American College of Radiology recommends that women do a self-breast exam at least once a month because no one is going to know your body better than yourself. So any changes you notice month to month would be a red flag or something that you can. I have so many women that come in that find their breast cancer on their own. They're the ones that found it. And I can't tell you how important that is. Yeah. Yes, ma'am.
Just a comment on that question, though. Mammography will pick up the cancer before it's big enough to feel it.
Correct.
And I'm the poster child for that, okay? I went for my mammograms every year religiously. And I had already had 2 biopsies for microcalcifications, and they were benign. The third one was the charm, and my tumor was 0.7 centimeters.
Wow.
Okay, nobody could feel that. And had I not gotten regular mammography, who knows what would have happened.
Yeah, thank you for sharing your story. That's the most compelling reason. That's why I'm here. That's why I like to tell everyone about it. I mean, I feel like, you know, mammography saves lives and I see it every day. I do see it every day. I diagnosed 4 breast cancers today that were less than 2 centimeters. So, you know, I feel like, you know, women only knew how important it was. And that's why I'm so glad to be here. Anything else? Anyone else? Well, thank you
both so much. It's really, really.
Absolutely.
fascinating. Thank you.
Thank you. Thank you. Thank you so much.
Our guests brought little goodie bags for everybody. Nice. It's something personal I didn't want to.
Okay, yeah, sure, no problem.
So I have a little taste, and my last